Can you define prolapse?
Keep the pelvic organ where they used to be.
And you seek attention.
Immediately. Pessaries, I call them vagina bras. It sits in the vagina and it offers circumferential support.
Do you know much about cognitive behavioral therapy for bladder control?
A lot of stuff is behavioral in nature.
I feel like the weight is still on the woman to try and figure it all out.
We're not coming in so much better educated now.
I'm Dr. Beatrice Seguin, PhD, and you've landed on my podcast this time of the month, your trusty sidekick to the midlife roller coaster. I chat with experts digging into legit solutions for midlife hurdles, be it health or lifestyle. Ready for the ride? Dive into this time of the month. Subscribe and catch the latest episodes on our channel. Let's own this midlife magic together. Did you know that there's a direct correlation between your breathing and your pelvic floor health? My mind was blown on today's episode. I learned so much from our very compassionate guest, Gerda Hayden, a pelvic floor physiotherapist. Today, you're going to learn so much about pelvic floor physiotherapy and how to quickly address a lot of issues you may be experiencing. In fact, you're probably going to want to run to her practice, especially if you're suffering from something like incontinence or a prolapse. Gerda shares the best exercises to help us reduce pelvic floor pressure and how journaling your liquid intake, I said journaling, yeah, I did, it can help you understand your bladder triggers. This episode is jam-packed with tons of education and tips for those going through peripartum, so around childbirth, all the way to menopause. Stay tuned. Gerda, welcome.
Thank you.
So, what even is a pelvic floor disorder?
Correct. So that is really, I feel, Beatrice, a place where I love to start my conversation, is just educating women on their pelvic floor and on pelvic floor function. So I thought I'd bring in my model, which just is a nice segue to understanding exactly what the pelvic floor is. So I'm deconstructing it as we speak. So we have, I'll speak to the pelvic organs just now. So essentially the pelvic floor is a combination of muscles, of fascia, and a lot of other supportive structures within a bony framework, the pelvis. And the muscles in particular, we reference their origin as being the tailbone, the coccyx, and then insertion onto the pubic bone. So if you have a look at that, you can just see that the majority of the muscles sit towards the back. We collectively call that muscle group the levator ani, the lifter of the anus. So that's where a lot of the support function sits. And then the muscles become relatively smaller and less supportive towards the anterior aspect, so towards the bladder. We need to, though, and that is not shown in this model, consider the fascia, the connective tissue within the pelvis, because that is really what comes into play as we get older, as menopause starts creeping in, that we see this impact on the fascia. And often that is one of the key drivers to dysfunction. So if we look at the pelvic floor, it has a support function. It supports the pelvic organs. So that's what I was sort of taking out. So we have the bladder at the front. We have the vagina with the uterus sitting snugly behind it. And then we have the rectum sitting at the back. So we have these pelvic organs that sit in very close confinement within the pelvic rim. And then when we're lying down, we'll see the urethra, so that's where the urine comes out, the entrance to the vagina, and the rectum. So any dysfunction then, and these are the symptoms that often drive women to seek my care or my help, is bladder changes. And that can be incontinence, that can be urgency, that can be frequency. So anything that just feels different from what they are used to, changes in stream, altered voiding patterns, any vaginal concerns. And that can be pain with intercourse, that can be vaginal dryness, that can be a sense of heaviness, which often leads into a prolapse conversation. And then rectally, we can have constipation, we can have problems voiding, and even anal incontinence. So really, when there's a conversation about things feeling and working differently, that's when we need to look at what is the health of all those pelvic floor structures.
So that is fascinating, and to visualize it, especially the sort of the back part is really helpful. Is it just a matter of the aging process with respect to how our fascia is holding things together, or is it estrogen related? Talk us through that.
A bit of both. Yeah, a bit of both, right? As always. So as we start the perimenopause and menopause journey, overarchingly, we're seeing a decline in estrogen. And estrogen has about 400 known functions in the human body. And a lot of that pertains to the pelvis, yes, but every cell in the female body has an estrogen receptor. So when we see this decline in estrogen, it impacts everything, but particularly in the pelvis, estrogen is what keeps things plump and moist and luscious and full. And so when we have this decline, we see things just not being as optimally supported, right? So that is the connective tissue piece, that's the estrogen piece. But then if we have poor diet, we are not looking at fiber and water for gut health and bowel health, then we are probably also not exercising optimally, and then we are impacting muscular tone, not just in the pelvic floor, but overall. So it always just is
it all adds up. Yeah.
It all just adds up.
And if someone has children, births also,
correct.
That's another
correct. So we speak of childbirth as a once-off trauma event, and I say that with the greatest hesitation, but it is just a monumental piece to the pelvic floor, which is what I love about the womb where I work, because I'm seeing women in their pregnancy and postpartum phase, and if we can optimize pregnancy and birth outcomes, then we're also impacting what that pelvic floor is going to be doing once a woman hits her mid-40s, early 50s. So that transition of care is it's really what I'm passionate about.
That is, it's making me take pause, because I don't recall getting any peripartum care.
Yeah.
As I'm listening to you, I got this flashback to when I birthed my children, and I don't know if this is a cultural practice, but my mom told me to wrap. I would bind, essentially, or wrap. Was that good or bad? I have no idea.
What was her messaging to you about that? Do you remember?
If I'm really think back, I probably was one of these women who internalized, I'm going to cry, the message that this kangaroo pouch.
Yeah.
And you got to put it back real fast.
Right, absolutely. And so that's often where I start, is like, what is the belief behind it?
Yeah.
Okay.
And then a belief that there's muscle strengthening. My mom was coming at it, I'm sure, from a good place. So it was a combo of my psychology of how I felt, and probably her telling me, do this, it'll help it.
Yes, reconnect or reestablish itself. So, I think knowing that we have the muscle capacity to stabilize and support those core muscles, and by core, it's rectus abdominis, it's diaphragm, it's transverse abdominis. There's so much to our core. We have the capacity for those muscles to work synergistically postpartum, and for there not to be a need for binding. Okay. A lot of women will come in though and tell me, like, between 5 and 7, so witching hour, the back pain and the mental load, it's just too much. For me, then, the wrap is almost like a hug or a support strategy. When we are tired, and by then, like, your body is just done, milk production, you're probably facing an interrupted night's sleep, put on the wrap. If it makes you feel better, put it on. But does it offer any actual changes? No. But I'm all for a good sports bra, because my posture is better.
Yeah.
And I stand up and I actually engage those muscles. So if I'm watching Women for Women and I see someone just walking in like that, I'm like, maybe a bind or a wrap just to help her take a deep breath and stand up straight. The other controversy around that is if we view our body as a toothpaste tube, not the sexiest idea, but if we're squeezing around the middle, the pressure tends to go upwards and downwards. So if there's a lot of binding, a lot of wrapping, and there's a lot of cinching in, often we're not breathing properly, and those pressures are often then translated down onto the pelvic floor, which postpartum then isn't great either. So when women come in and they are looking for a recommendation, I often send them to a site where there is a compression legging that offers support through the entire abdomen, through the sort of pubic area, right up into the rib cage, and then they're getting that full body compression, and that often just makes them more supported and comfortable rather than this just abdominal piece.
Is this standard, or is this something a woman has to seek? We're in Ontario, so I mean it may be different.
Yeah. So Ontario-wide, it is something that a woman needs to seek out. Currently, pelvic health physiotherapy is not covered by OHIP, so it is an out-of-pocket experience. The French have really pioneered this, so a woman will see a pelvic health physiotherapist for 7 to 11 visits postpartum in France, and it is covered. It is just understood that once you've had a pregnancy and then a baby, that you will seek pelvic floor help. It is not the same in North America. I think Europe is segueing into that, but it's a cost-implicated service.
But the poor outcomes that a woman will experience later in life as a result of birthing, that has to have a cost. And in society, it's just mind-boggling. I do think I read somewhere that the outcomes for the women in France are better. They have less impact.
Correct. And what I will just little teaser, pelvic floor physiotherapy is not like normal physiotherapy. We find that we can have 2 to 3 sessions and really make a massive difference, not just on the symptoms, but just in pelvic health long-term and going forward. Where if people have had an experience with a traditional physio, and I've been an NMSK physio for half of my career, you sort of have the ankle injury, you need to see the physio twice a week for 3 to 4 weeks, and then you're likely to have a repeated ankle injury anyway. Where pelvic health physiotherapy, and that's why I'm in this line of work, it's super rewarding, and the turnaround time often is remarkably short once women understand what's going on.
So I want to know more about that, but just MSK. What is MSK?
Neuromusculoskeletal.
Okay, so good to know.
That is I hate to say normal physios, but that is the sort of standard training that you leave university with. And then if you want to go into specialized training, which is what I've done, then you have other sort of brand names that you can tack onto your credentials.
So what would that look like then? What types of I think we really do need to go back. We may even need to go back to before. And some women choose not to have children, but just what do we do in our young life? How do we set ourselves up for pelvic success?
I'm going to say that is probably going to be a product of overall well-being. So and that is where that holistic piece that I'm so passionate about comes in. If we look at our well-being as based on 5 foundational pillars, it's sleep, it's good nutrition, it's mental well-being, sort of psychological well-being, it is exercise, and there's another one. It will come to me. I speak about this all the time, and here I am, ding, 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 5, and I can list 4. So these foundational pillars really influence the way we live our life, and I want the pelvic floor to be like the muscles in your eyeballs. You never think about them, right? When we are in a well-lit room like this, and I were to step into a dark room, I would need to coach my eyeballs into changing the light intensity. I would just anticipate and expect that those muscles are taking care of that. And so that is what I want the pelvic floor to be able to do. And so understanding that is Functionally, the majority of those pelvic floor fibers are postural in nature. So if we are upright, if we're exercising, if we're having daily poops, if we are having orgasms, shout out a great pelvic floor like strategy is an orgasm. Yes, it's an exercise. There's one of my colleagues who's like 3 orgasms a week, takes care of your pelvic floor training. So
sounds better than an apple a day.
Right. Yes, ma'am. So I'm going to say, as a young person, look at everything. Like, there's no real piece that I need you to prioritize. If anything, bladder habits. Let's talk bladder habits. Out of the just in case peeing. I just went before we started filming because big moment for my bladder. But a lot of us girls have been taught to empty our bladders before a long car trip or leaving for the mall or whatever, because our parents, our mothers, had some bladder issues. And so they were trying to empty their bladder sort of in anticipation of a cough or a sneeze happening. And then they were teaching us. Meanwhile, our pelvic floors don't have any dysfunction as young children. And so a lot of stuff is behavioral in nature, and that is a key piece to like look at as a young woman. So that's often what I speak to.
That's fascinating. So you mean that if we quote unquote force ourselves to pee, that is actually not good for us in the long run?
Correct. We're disrupting the bladder's feedback mechanisms to the brain, alerting us about filling capacity. So if we're constantly overriding that and emptying when we don't actually need to, that just changes the way the brain perceives the bladder's status.
Is there such a thing as even the posture when we're peeing? Again, socially, you know, how am I supposed to sit on the toilet?
How are we supposed to pee?
Yeah.
Okay, so just as I was sitting here, I'm like, it's so funny. We are on camera, yes, and we are knees together, right? Inner thighs, just lots of like contracting. Peeing, pooing, if we are backcountry camping, we are in a position where our knees are higher than our hips, okay? And that, for emptying purposes, it allows the pelvic floor to fully relax, which is what we want to happen. Sitting in this 90-90 position on standard Western toilets, actually there is a bit of tone still in those pelvic floor muscles. And then we need the bladder to work harder, and we need the rectum to like work harder to expel, where it should just be an easy process, in, out, off the toilet, away we go. And please, no more reading. Or
so is this
Instagramming.
Bad? Instagramming on the toilet?
Because we are at that point in the voiding position, the pelvic floor muscles are completely relaxed. And if we are then adding just gravity on our pelvic organs, there's a certain degree of pressure that is now not being supported by the pelvic floor muscles. Over time, that's just not, it's a very vulnerable position for our pelvic organs. Ask any mom who's just given a birth to a baby. She does not want to be hanging out on the toilet for an extended amount of time. She wants to get off and be upright again, where the pelvic floor muscles have tone and are helping and supporting.
Well, I just learned something. I had no idea. So
squatty potties.
Squatty potties. Do we need poopy benches?
We can play around with those words, girl, all day. I love it. Essentially, though, it doesn't matter. I just need something that elevates your knees higher than your hips.
All right.
But poopy benches, yes, I think there's a niche there.
There's a niche. I think we need to. Okay, so holistic, just good health behavior helps every part of our body.
Correct.
So, okay, so now let's go back to the types of things you would tell a woman who is in peripartum phase. So some key things.
Peripartum, so
peripartum.
Okay.
We'll take it from childbirth and then we'll move to menopause.
Correct.
Yeah.
So we've dealt with the younger woman. If a woman is now considering fertility, her pregnancy journey, there are some studies to suggest that doing like a release fascial connective tissue work on the lower abdomen does improve fertility outcomes. There's a group, I think, down in Florida that has actually got a registered trademark on an approach to optimize fertility outcomes. I think, again, movement, good blood flow to the area is going to be of vital importance to improve your chances of falling pregnant. So that's one thing to consider. And then really coming in, having assessment and understanding what is your status quo. What is your pelvic floor doing? Most nulliparous, or women who haven't been pregnant, women in their 20s have pelvic floors that are, relatively speaking, presenting with higher tone. They are just more muscularly active. But if there is, like I say, if there's no pain with intercourse, if there is no obstructed defecation, then I'm not going to pathologize that.
Yeah.
If there is pain with penetration, that obviously is going to lead to less penetrative intercourse, which will then impact fertility rates and outcomes, because if you're not having sex, then you're probably not going to fall pregnant.
So these are not just older women issues. The pelvic floor issue, so I was thinking of, as we are getting older, we have the more the laxity issues, but there can be too tight.
Correct.
Fascinating.
Correct.
So,
yes.
In what circumstances would that happen? Is that physiological?
Correct. So a lot of our elite athletes will have an upregulated pelvic floor. So gymnasts, dancers, ballerinas, that kind of, where there's a lot of emphasis on this posture piece. Those might have an elevated pelvic tone, and then it's really one of the sucky pieces of my work, but if there has been trauma or abuse.
Yes.
And your pelvic floor muscles, if I were to speak of the functions, anatomically and physiologically, it supports, it's there to optimize continence and then voiding and all those pieces, but your pelvic floor is one of the first line responders to a fear-based trigger. So they put electrodes on men and women and got them to watch a scary movie. And they were wondering, is it the increased heart rate? Is it the sweaty palms? What happens first? And they found across the board, your pelvic floor has done that long before anything else has happened when those scary zombies come running at the screen. Because back in the caveman days, we were not peeing, pooing, or having a baby. We needed to get out of wherever we were. And so the pelvic floor is still doing that. Our saber-toothed tigers, though, are now buses and emails and the work-life balance and picking up kids and taxiing them everywhere. So there's often just this increased tone just because of life.
Yeah.
It's 2024. There's a lot going on. I think we're still compensating from COVID, so just cramming in as much as we possibly can. And we're finding that is just showing up often in more tone.
So if there's tone that can lead to pain or other issues, what do we do?
So then we have a lot of down regulation strategies that we need to look at. We can base those very much with a focus on localized down regulation, so guided meditation that focuses on the pelvic floor. But I'm also very much, what is it that allows you just to breathe and calm down? Is it a walk in the forest? Is it taking your dog, on the weekends and going for a hike in nature? Is it going to that hot yoga class that you've loved doing but just haven't made time for? So I'm very much, again, holistic. What is it that allows you to connect with yourself and brings down that sort of tone throughout the whole body? Because again, it's just a muscle that responds to life like all the other ones.
All right. So now let's move on to the opposite problem. As we reach our perimenopause, we're waking up middle of the night peeing.
Yes.
As one of several symptoms. So what can we do there? What types of exercises? Yeah.
So the North American Menopause Society, and I really take my cue from them quite a bit. I attended their conference in 2022 and I saw big farmers.
We were probably there.
Yeah.
I was there.
Yeah. Georgia. Atlanta.
Yes.
No.
I was there.
I looked at all the pharmaceutical support and I was like, it's just going to be pill pushing. I really thought, here we go. They're just going to tell us to take XYZ pill and everything will be fine. But there was such a beautiful focus on other allied interventions.
Yeah.
And I'm like, now you have my attention, because that really resonates with me. So their recommendation is, let's start with, if we have mild vaginal symptoms, let's get a hyaluronic vaginal moisturizer onto that tissue. And then we can deal with the dryness, we can deal with the pH changes, because that's one of the roles of estrogen, is that it keeps the vaginal environment very acidic, which is why the vagina can sort of keep itself clean. Once that acidity level changes, we have an overgrowth of bacteria that are just living in that area that come up the urethra and are causing often repeat urinary tract infections that on swabs and clinical collection don't show up with anything, because it is often E. coli, which is prolific around the anus.
Yeah.
So if we keep the acidity at that sort of 3 point whatever level, then we can often circumvent a lot of that. So low bothersomeness, hyaluronic acid vaginal moisturizers.
And that we can just get at any
over-the-counter
drugstore, pharmacy. Yeah.
Correct. If there are things that are a bit more bothersome, speak to your doctor about maybe an estrogen, a local estrogen. And then we need to have a conversation. Are the symptoms that we're experiencing at menopause global? Is it the night sweats, the hot flashes, the brain fog, the mood? Is that the main bothersomeness, or is it local stuff like prolapse, incontinence, urgency frequency, nocturia, all of those pieces? And then we want something probably just local. So it really just depends on where exactly a woman finds herself with the symptoms that are bothersome to her.
Does a woman come in the journey through you first, or family physician, a little bit of both, gynecologist? Like, how do you work in that ecosystem? I feel like it's so siloed. Sometimes it's not one or the other. I feel like, can you sign me up for everything you just said?
Absolutely. And I think that's my frustration. I can do a lot of the education pieces, but then my hands are tied. If a woman opts for the estrogen piece, then I need to send her back to her medical doctor. And often the medical doctor isn't familiar with the rationale, or is hesitant, or doesn't want to prescribe estrogen because of the cancer piece, which we now have pretty much refuted, but it is still a myth that is out there for sure. So there's a referral to the gynecologist. The wait time for that is 18 months. So it's just so frustrating. So often I just say to women, start with the vaginal moisturizer. Just get something onto those tissues to ease symptoms, and then let's just go through those correct channels. But you're not arriving at your gynae like at the brink. You've got some measures in place.
And we've talked on previous episodes about the risks and benefits of systemic hormone therapy. Viewer will put some links and remind you of what those past episodes are. And I think really I want to emphasize when you mentioned the local estrogen, the vaginal topical estrogen, that again in many studies, and speak to your physician, but that's local. It is not the same as the systemic therapy, so it can really help with some of those symptoms. It's sad that I feel like the weight is still on the woman to try and figure it all out. So I'm going to go to my physio, I'm going to go to my doctor, gynae, and then try to get the help I need.
Correct. But what I really appreciate is that women are coming in so much better educated now. So it's these kind of episodes and it's Instagram posts. I really enjoy the Facebook community group, Menopause Chicks.
Yes.
Shirley Ware. Yeah. Just someone who's wanting to get good quality information. And so women come in armed with that now. And I'm like, yes, now we can have a conversation. It's just that the wait times just are still...
They are
impacting.
Knowing that you follow the guidelines of the Menopause Society, the recent publication with the evidence-based treatments, I noticed that cognitive behavioral therapy was one of them.
Correct.
Who delivers that? Would you do that in your practice? Like how?
So cognitive behavioral therapy was especially found to be very helpful for insomnia. I think that was the sort of the big one that came to the forefront. I haven't done my training. I looked into it after that conference because there was someone I feel in Ontario who was piloting that. I haven't pursued it. Often the herbal remedies allow women a bit of relief, enough for them, for the clients that I have seen, to improve sleep quality and thus a lot of the other bothersome symptoms. But if there is a woman who's just chronically insomniac and really battling with it, I will direct her to CBTI for the insomnia piece. Websites there are, and that's a beautiful thing about it. It can be self-directed learning. So it is something that I would like to arm myself in my toolbox. I just haven't gotten around to it yet.
Do you know much about cognitive behavioral therapy, CBT, for bladder control? Because someone mentioned that to me, and I was very curious about the evidence and what that looks like.
So really, the CBT piece is, again, understanding and being aware of what our bladder is cueing during the day. And then I usually start with a bladder diary. And a bladder diary just tracks over a course of 3 to 4 days. What are you consuming, especially fluids? And what is your emptying or voiding profile? What does that look like? So often women will find they get up, they pee, they have their first coffee, they pee again. Then around 10, 11, they have another coffee. They pee predominantly during the morning. Then there's this big sort of like dry spell, should we say, in the early afternoon. And then they realize they haven't had their 8 cups of water and they chug stuff back between 5 and 7 like they were born to do this. And then they are peeing all the time before bedtime. So what we know now about the bladder is that it is not just synonymous with the detrusor muscle. So the bladder actually has 5 layers. And the layer that is most superficial has little receptors in it. And we know that those receptors don't like being excessively stretched. So sipping our fluids throughout the day keeps the bladder generally much happier than who just I can map 500 mils, no problem. But my bladder will let me know 10 minutes later, I've just been stretched to the max. We need to avoid in case she does that again. Where if you just even it out, we just get much better, happier bladder. And often just that change has taken women from like urgency, frequency that was driving them nuts, nocturia, to a bladder that was perfectly happy.
That is so helpful. I love looking at things, what are the root causes?
Correct.
Journaling. We've had another guest on the show that talked about tracking and journaling your general symptoms, but I would have never thought to journal my liquid intake and my bladder sort of habits.
Yes.
So that's a really great takeaway.
And often there's I left to go to a meeting, I'm going to pee, even though I've just peed 30 minutes later, but I'm about to leave the house, so I'm just like touching up my makeup. Why don't I just have a pee? And then I'm like all empty and good to go. And that's then the stuff where I'm like,
I feel like many of us do this.
Well, we all do it.
Yeah.
We all do it. But then having insight and awareness, can you then get to decide, is that something that is bothersome to me? Do I want to address that? Or it is what it is.
Yeah.
Like I think my big piece when a woman has come and seen me is like, do you have an awareness of your pelvic floor now? Because a lot of pelvic floor exams get done to us. The stretch and sweeps and the cervical check when we're about to give birth, the pap test, there's a gown.
The dreaded pap test.
There's a doctor there doing something to us, and then we get it in the post. I take women on the journey with me, and I'm like, I need you to know what your pelvic floor is doing right now. I'm a stranger, I've got blue gloves on. Your pelvic floor is probably going, what is she about to do? But know that. That's normal. I want your pelvic floor to be apprehensive about an exam, but then can you have the control to relax those muscles? Do you and give you that control back rather than just this very passive approach to the pelvic floor?
Shall we tell our viewer what a pessary is?
Let's do it.
Let's do it.
Okay, I brought stuff. So essentially, I find this is a really great way of understanding key differences about pessaries. So we have support pessaries, and those have a more rounded shape. And then we have space-occupying pessaries, and those are the ones across the top here, and including the donut. I personally don't like fitting donuts. I feel we have Tim Hortons around every corner, which is the land of the donut. So I'm like, I do not need anyone to have a donut in their vagina. But that's just me. Okay, so your support pessaries are designed really, and I've got one here, to be particularly for stress urinary incontinence and mild bladder prolapse. So if we have a look at the vagina, we place this pessary into the vagina like this. And in that way, the front, so if the bladder is sitting in front of the vagina, your vaginal wall then has a bit of a structural support, which means that the bladder can lean into something that is offering a bit more resistance, because prolapse essentially, which is what pessaries are for, prolapse just means that this vaginal connective tissue sock is not offering enough structural integrity to keep the pelvic organs where they used to be.
Right.
Okay. So the bladder, if the front vaginal wall is relatively more lax, then the bladder will lean into that wall, and we can see a bulge at the entrance to the vagina. I am never seeing the actual bladder. I am seeing the bladder leaning into the vaginal tissue and the vaginal tissue bulging out. I always say to my clients, if I were to ever see your bladder, I would personally drive you to the ER.
Right.
That is an internal organ. It will always stay inside. So a prolapse, we're always seeing just vaginal tissue.
Okay, and can you define prolapse?
Yes. Let's start with the rest. So prolapse then is the descent of pelvic organs from their normal resting position in a way that is bothersome to a woman. So we go often by symptoms and women coming in and saying, it feels like I've got a tampon and it's falling out. I feel heaviness. There is something protruding. I'm sitting on an egg. I feel something when I wipe, when I'm washing.
Okay.
There's something there. Okay.
And you seek attention for that.
Correct.
Immediately.
Yeah. Okay. The thing about it is that there comes a point where we all will have some connective tissue changes, meaning that our pelvic organs won't be sitting in the positions that they did when we were 22. Okay.
So can we say they're like descending? Would that be a correct term?
Yes.
Okay.
Yeah. It is. And I also had a great thought. I'll get back to it. So they are descending from their original position, and then we refer to what is descending as being either bladder prolapse, and that's when the bladder is descending, the uterus, uterine, or the rectum, and that's a rectocele. Some women decide to remove the uterus, a hysterectomy, and then they are left with a little vaginal cuff in sort of where the vagina ends, and occasionally that little vault can descend too, and we call that a vault prolapse, or the intestines sort of fall in and we can have an intestinal prolapse. There's lots of different types.
Right.
The big piece is that physiotherapy cannot really change the degree of prolapse. Once that connective tissue has descended, it's descended. But we can do a lot about symptom bother. And that is the main thing that women come in with. And if I can say to you, I'm going to improve your symptoms so that you're not as bothered by it. If you were to take a mirror after 6 months, you would probably still see a bulge to a certain degree, but it wouldn't impact your day-to-day living, a lot of women are like, game, yes, that sounds great.
So back to the pessary. So would this be considered kind of, in the order of escalation of intervention?
I will start with understanding what's going on.
Yeah.
Okay. Then we do some pelvic floor muscle training. We make sure that we're not constipated, and we make sure that we manage our intra-abdominal pressure well, which is essentially, let's not hold our breath ever again, ladies. Keep breathing.
Easier said than done.
Absolutely. We often default to any lifting, carrying, pulling, pushing, bracing and holding our breath. And that just means that there's a lot of pressure that is acting downwards on our connective tissue and our pelvic organ. So that's always where I start. If we find we're just not getting the results that we want, then we start talking about pessaries. And I view them, I call them vagina bras.
Vagina bra.
Because just like our breasts are just not the same as they were when we were 22, and we now use underwire. There's just no negotiation about that. Or if we were now to go and do a 5K jog,
wear my sports bra.
You would put your sports bra on. So I say to women, this really just is like a bra to your vagina. It's something that you insert that gives the vaginal connective tissue something to work with that can just ameliorate those symptoms of everything descending.
Does a person take that off? No, it's you who puts it in. How does...
Okay, hang on.
Details.
Yes.
Okay.
So support, round shape, typically for bladder concerns. The one I usually tend to fit is more this shape. It's a cube. And it sits in the vagina, and it offers really circumferential support. So it's not just the front wall that gets the support, it's all the way round. So if a woman has a rectocele, so if the rectum is descending, this one in particular is a great one. And these little concave walls means that it actually suctions to the vaginal wall, and this sucker does not move. And when you are active and you want to be doing your Zumba and your CrossFit, this is the one to go for. I fit them. We need the gynaes or a family doctor's okay, just in case there are any contraindications that I may have missed, just because I don't have the medical clearance for identifying certain contraindications. I fit them, and then I teach you how to take them in and out. I need you to be able to look after them, just in case you find they are irritating you, there's an accumulation of secretions or just an odor. No one likes an odor, we're women. So I need you to be able to look after them. So the ring is fitted by, you come folded in half, and then that gets inserted into the entrance of the vagina. And at a certain point, it just opens up. And then this one, you squeeze corners together and you insert a sort of an edge or a corner of the cube. And once women have tried inserting one, a lot of them just go, it's like putting in a tampon or the menstrual cup. I think most of us now have put things up our vaginas.
We can learn, especially if it helps improve symptoms. All right, so that was completely, for me, I'd never heard of this, so really educational. What happens, is there then another, do we go from here to surgery, which then obviously scope of work goes back to gynae surgeons, but is that the next step?
That would be the next step, but often a lot of gynaes, we have more of a symbiotic relationship now, which is really exciting to see. A gynae really appreciates it. If a patient walks in and goes, I've tried this, it gives me 7 out of 10 relief, or I just feel I would need the next step, because the SOGC, so the Society of Obstetricians and Gynecologists of Canada, for grade 2 prolapse, which is the most common degree of prolapse, pessaries now are the first line treatment.
All right.
So a lot of gynaes are getting, with these wait times that they're experiencing, if someone comes in with a grade 2 prolapse and they're like, you're actually not a candidate for surgery yet, and then they have to go back to someone like me to fit these. Gynaes also fit pessaries, by the way, but turnaround time is just a lot quicker if you were to come through me. A lot of them just really appreciate also all the education pieces around constipation and pressure management. And so I make them look good because the surgical outcomes are so much better if a woman understands what has led to the prolapse in the first place.
I mean, my dream team is, you know, I don't know why it has to be always an either or. It really shouldn't be. My dream team is pelvic floor therapist, family doctor, gynecologist, all talking to each other around the woman's issues and figuring out. It's like you're fielding. Who takes this one? But we all know what's happening to her and we're all talking.
Correct.
Can we put that on the dream map for healthcare, menopause care in Canada?
Absolutely. Let's do it.
So what else would I want to know about? You know, I am not familiar with these things, but are there some things that don't work as well? I've been at dinner parties and I've had actually some community members ask about machines you sit on.
Yep. So the two things that probably come across my desk the most are a conversation about vaginal rejuvenation lasers.
Okay.
And the chair, the Emsella chair, okay? I'll speak to both. Let's start with the chair. So essentially it's high frequency electromagnetic rays that are being introduced to the pelvic floor, rays, contractions. And we are getting something to the degree of like 10,000 pelvic floor contractions per 30 minutes sitting on this chair, which sounds fabulous.
Okay.
And it is if there is true pelvic floor weakness. Okay, if that is really what is going on, then those chairs are magic. You have 6 sessions, you sort of interspace the sessions, I think it's once a week. And then usually they have a bit of a follow-up 2 or 3 months later just to make sure that we maintain the gains that have been made. I will say though, I collaborate with a team that runs one of these centers. They are Core Life Wellness out of Oakville Trafalgar Hospital. And we often refer clients back towards each other because that is a first line entry point for a lot of women. They go and say, I have prolapse, I have incontinence. They go there. And then through the intake, often might be something else going on. Right. So I then do a full medical and we just figure out what exactly is happening at the sort of core of it all. And if it is true weakness, off they go to the chair. And we have had fabulous results. If there is overactivity, and sometimes that can present with incontinence too, the pelvic floor is already so engaged that if you cough or sneeze, it cannot generate any more forced closure. Then sitting on that chair for 6 weeks is not going to be a great idea, right? Because we're just going to increase that tone to like just very uncomfortable degrees. So that's the chair. The other one, and these, so at 2022 at NAMS, at the conference, vaginal laser did not get any rave reviews. No. They were just saying the depth of penetration and the degree of benefits just don't match what people are putting out there.
Yeah, and I think there's also the way it's marketed, laser rejuvenation. So it's really more about...
yes, very much a youth-focused.
A youth-focused, which is different than treating genital urinary syndrome of menopause, GSM.
Correct.
And from the NAMS publications, there is inconclusive. I believe it's just inconclusive at this stage.
So I went and I reviewed what has happened in the past 2 years.
Okay.
And so you have erbium lasers and you have carbon dioxide lasers. And then there was differing opinion about which is better. Again, it seemed to be like they sort of do the same thing. And if there is a benefit, it tends to like resolve or return back to baseline after 12 to 18 months. So a lot of financial outlay for something that is just going to return to baseline a year later.
Right. And NAMS, current first-line treatment for GSM, remains
hyaluronic acid and estrogen.
And estrogen, that's
Correct,
right, or hormone,
yeah.
menopause hormone therapy.
Yeah.
What haven't we covered that you come across in your practice and you're like, I need to share this. Every woman needs to know this about her pelvic health.
I'm going to say one that I had not included in my questions, because often I have sort of a standard list of questions, and then a lot of women would come at me and mention this, and I'd be like, huh. And that's anal incontinence. I think we're getting better at talking about menopause. I think we're getting better at talking about incontinence. We know that 1 in 3 women pees herself. We know that 1 in 2 women will have prolapse. Anal incontinence, so the involuntary loss of fecal matter, either gas or stool, is 1 in 5.
Wait.
And we're not talking about that.
1 in 5 women, lifetime. Like, we're not talking perimenopause, menopause. This is just a...
It peaks.
Peaks.
Peripartum and perimenopause, because the anal sphincter also has all these estrogen receptors. And so the problematic thing about it is that we don't have great conservative strategies. So pelvic floor muscle training has very strong evidence of being great for prolapse symptoms and for stress urinary incontinence. It's not that great on anal incontinence. So it's a trial. We sort of
It's
some
the Wild
training.
West. We don't know because there's no research.
There is
or not enough.
Exactly. And the other interventions involve like surgical options. And if you've just had a baby, often the last thing you want to do is have a surgery to your anus.
Crazy question. If vaginal estrogen works, would and
So
you
they're
just said
trialing
we're
it.
lined with receptors, so there's no data yet, but
Correct. Okay. Correct. So that's where the thinking is going now.
Right.
But again, I think we need to start cracking open the conversation, because once women are talking about it, that's when research starts funding things. But if we don't mention it, who knew?
And not only do we mention it to each other to make it less taboo, there are things we can do. We can use our voice. We live in democratic countries. We can contact and we live in Canada, so an MPP is the one you would reach out to for access to care. Correct. This whole France thing, people, we got to put that on the map.
Yes.
Why don't we have that
Yes.
here? On a research front, in Canada, you're approaching it's a federal issue, so your MPs, if you're in the US, Congress, who do you approach in the US? But the point is, we can speak with our voting voice.
And especially in the pelvic floor world, it doesn't take that much. You know, like from a cost perspective, because ultimately that's always informs decisions. It's a relatively basic intervention that would yield massive benefits down the road, and we're living longer. Like, we're getting into our 80s, 90s, 100, and quality of life arguably is what we're wanting, not just longevity. And if we are leaking, and if we're not wanting to leave the house, and if we're having hip fractures because we need to pee at night because we're peeing up 5 to 6 times a night, that has massive impacts on our healthcare system, because we little old ladies...
the cost of that would be much bigger than actually trying to prevent those things.
Correct. And I think that's where that's my hobby horse. It's just...
So if we think of 1 billion women going through menopause by 2025, and for the exercise only, we're just going to say 1/5 of that. Imagine 1/5 of those women suffering from pelvic floor disorders, including rectal incontinence. That is a lot.
That is a lot. Yes.
It's a big burden.
Correct.
Okay, so tell me more about these interventions that pay in droves in the future. Tell us more. What can we do? Yeah.
So we understand as good pelvic floor function to be the ability to do 8 pelvic floor contractions that we hold for 8 seconds each, and then 10 quick contractions successively.
Like contraction.
Okay. So the easiest way to connect with your pelvic floor actually is to pretend that you're tightening around your anus. Okay. That is it. There was a lot of focus previously on stopping pee midstream as a strategy. Once off, I'm fine if women try and do that, but For a bladder-brain piece, when you're peeing, your bladder is contracting and your pelvic floor is relaxing. To suddenly ask the bladder, the pelvic floor to tighten can sometimes really disorientate the bladder because it's, hang on, I thought this was my time. We're on the toilet, so what's going on? And that, if we use that as an exercise strategy, can sometimes lead to urinary retention and issues like that. So tightening around the anus on an exhale, because the pelvic floor and the diaphragm mimic each other's movement. So on an inhale, both descend, and on an exhale, both ascend. So as you exhale, tightening around your anus, and then inhale and let that contraction go.
Got it.
That is 101 pelvic floor muscle training.
8 times a day.
2 to 3 sets. If there is a dysfunction, if there's a weakness, we want to do 2 to 3 a day, 3 times a week for 3 months. Okay. If there is overactivity, then we speak about all of those down training strategies that I've mentioned, or the relaxation pieces. So the intervention then is, let's understand what's going on in our pelvic floor. What are the contributing factors? Can we do 8 times 8 and 10 fast? If we can, great. If we can't, let's work on that. And the pelvic floor has such good innervation. It has such good blood flow. It's seldom really injured, except maybe in a tricky childbirth. Those muscles are there and they're ready to fire. And we use them all the time, like when we sit to stand. So there's no excuse for not incorporating some degree of awareness into our daily movements, and suddenly the pelvic floor goes, yep, I know this is what I need to do, and it runs with it.
Wait a minute, Gerda. You're telling me there's a controversy around planks and other types of exercise? What is this?
Okay. So this is a conversation that often gets picked up postpartum with regards to diastasis rectus abdominis, which is that idea of a separated abdominal wall, which it's connective tissue that has stretched during pregnancy, because we have to stretch the abdominal wall to fit a human baby inside of us. So we're now just trying to reframe that and stop pathologizing something that has to happen in order for us to have babies, growing to full term. The idea was, if there was any doming or invagination, so if the central connective tissue line, if there was a lot of movement there with planks, sit-ups, then we were cautioning women against doing that and trying to sort of find alternatives. We've now landed at a place where we understand that to make something stronger, we have to load it. We need to expose it to something that is difficult. Otherwise, there is no impetus for change. Correct. So if I want to grow my biceps, I'd better start picking up heavy weights. Otherwise, my biceps are not going to have that needed input for change to happen. And that's what we're seeing now with the abdomen. Also, again, pressure management wise, they were noting that women who were doing a crunch or a small sit-up, that their bladder neck was descending. And it was like, we don't want that. We don't want any descent. And then they juxtaposed it to standing up and found that the bladder descent is vastly more when we just get to sit to standing. So if you're telling a woman not to crunch, you're also telling her not to get up from stand.
So don't live.
And that is where I find I have my big problem with a lot of the narrative. Exercise and movement for us women is non-negotiable. Once we hit midlife, we have to move for 1,000 benefits, for metabolic, for sleep, for estrogen, for all of those pieces. So when I hear women coming in and said, I've been told that I can't, I just have a really big problem. And then I like unpacking that why, and then it just becomes like a complete non-argument, is what I think about that.
Well, we need everyone to hear this. And I'm glad you brought the pathologizing thing up, because it's not just that, it's women feel bad. Like they've failed somehow, they've done something.
They're broken.
They're broken and they're trying to hide it, and yet it is normal.
It's normal, exactly. And so again, helping a woman understand that. And then in the postpartum phase, so estrogen is actually what keeps things really pliable and lax in pregnancy. It's not the hormone relaxin, it's estrogen. High levels in pregnancy. And then those drop off significantly postpartum. And that allows the connective tissue actually to like stiffen up again. So there's often a lot of healing that still goes on postpartum for up to arguably 12 to 18 months. So these moms that are feeling so crap about themselves 8 weeks postpartum because they don't look like the Instagram idol that they're following, I'm like, you've got another 12, 14 months before we need to talk about anything. So deep breath, keep moving, do something that makes you feel mentally good, and let's just allow the body to also just heal.
Okay, we've talked about things that are really good for our pelvic floor health. Are there any exercises that are bad?
Exercises, no. Movement-wise, no straining. I don't want anyone to be on the toilet, bearing down, holding her breath, trying to get the poop out. If it's not happening, get off the throne, have a glass of water, and try again when you feel the urge. This idea of having to like force things out, not conducive at all to the pelvic floor. Often use this when I have clients. So I'm going to do it with you. And I want you just to imagine that you were going to get up into standing. Okay? So I'm going to get you just to feel what that would feel like in your body. And tell me whether or not you would do that on an inhale or on an exhale or on a breath hold.
Breath hold.
Correct. Okay. So they've looked at intra-abdominal pressure, which is a building of pressure in results or in as a result of movement. And they were like, there's a lot of talk about don't do planks, don't do crunches. There's still a lot of fear-mongering in the movement world. And I'm like, listen, sit to stand increases intra-abdominal pressure more than any other movement. And sit to stand arguably is one of the basic activities of daily living that we do 1,000 times a day. So let's get into the habit of doing that as we breathe out for the sake of our pelvic floors.
Okay.
And I find doing something that is just relatable to everyday function long term is going to stick with you much more than if I ask you to do 5 Kegels a day, because no one does them. So let's just be honest.
Truth.
Exactly. So move mindfully, do things on an exhale, and your pelvic floor is going to be a much happier thing.
That reminds me of a previous episode where we talked about fitness snacking. So just making it part of your everyday, and then you don't feel like you're failing, right?
Yes.
Because if someone's telling me Kegels, I don't know how to do them, I forget, don't want to. So just incorporating these tips. So on an exhale, sit to stand.
Correct. So exhale with exertion or blow before you go. And then another piece to exercise, this is my favorite. The best exercise for us women is the one that we're actually going to do.
Okay.
So I don't do something that you love. Move your body in a way that feels relevant to you. But that is something, my walkers, keep walking. If it's my yogis, keep doing yoga. Zumba, I don't really care. For me, it's just move. Move and enjoy what you're doing, because then you'll do it again.
That's a beautiful message. And I am going to now ask you.
Here's a big question.
Gerda, what makes you feel beautiful?
Honestly, I thought about this because you were saying to me that this is one of your questions. When I talk about this, it lights me up. I'm passionate about women's health. Other than that, when I am in nature, when I've spent time outdoors, and when I'm with people that I really love.
Well, I felt the glow in your face when you were talking about all these things. I'm leaving this episode so much more informed. Thank you for being at this time of the month.
You're so welcome. Thank you.
You know I cannot help myself. When I'm in love with a product, I need the whole world to know about it. So I have this segment called Should I Like? It's usually products that I use in my everyday life, or sometimes my girlfriends tell me about it and then I fall in love with it. And now what's happening is some of these brands have graciously gifted some of their samples so that I can share it with our podcast guests. So I'm really thankful. Today we have the lovely tea company, and look at these heart-shaped tea bags. This brings me back to when my daughter was a toddler, and that is when we started the high tea ritual. This one is s'mores. It's a bonfire flavor, really fun for the summer. Also want to say thank you to Bone Brew House. I'm obsessed with these. They come in different flavors. This one is the coconut, and I'm actually going to try a recipe with it. You get extra protein, so easy to cook with. I will leave the websites for both of these companies, and I'm just so thankful that our guests get to take these home. Pretend you didn't see that, because that was your thank you bag. Thanks for listening today. This podcast is for entertainment and informational purposes only. The content shared here should not be considered professional medical advice. Always consult with a qualified healthcare provider for personalized medical guidance. We're here to empower and support you, but your health decisions should be made with your own medical team. Until next time, take care and keep thriving.